my pleasure to welcome you to the 2025 Norma and Albert Geller Lecture Series. I'm Richard Clark, Professor of Sociology, Criminology, if anybody doesn't know me. This is the 31st year we've done this. I think we missed a year. I think we missed a year during COVID. So this would be the 32nd year since you started this. This is my 31st year, John Carroll. So you and I have been doing this, well, I've been kind of hanging doing this lecture series for 30-some years. It's been a really fun ride. Thank you for everything you've done for the department and for John Carroll. We really do appreciate it. It's 31 years is a long time. So thank you kindly. Dan, thank you as well. So anyway, I will eventually turn the microphone over to Dr. Sean Chaplin, who's in the back of the room. He will introduce tonight's speaker. I would like to say a few words after I put on my reading glasses. The beauties of getting older. About Mrs. Geller. She's here with her son, Dan, and Dan's partner, Samantha. Welcome. Nice to meet you. Welcome. Norma Geller, Mrs. Geller, was a 1987 summa cum laude sociology graduate at John Carroll. In appreciation for the education received, Norma and her husband Albert presented a philanthropic gift to the department to be used for programs related to the betterment of human relations and the enhancement of human dignity. This lecture series is a result of that endowment. In addition to sponsoring the Geller Lecture, Mrs. Geller is involved in numerous other charitable and philanthropic activities, both here in Cleveland and in her winter home in Florida. Among these is the JCU Labor Project, which many of you know, where every Friday John Carroll students, again, this is my 31st year, to the best of my knowledge, John Carroll students have not missed a single Friday on Labor. At one point in time, Norma showed up for Labor and participated, and one time she took her son and her grandsons with her. And at the end of the night, the Labor folks turned to her grandson and said, "My goodness, young man, how old are you?" And he said, "I'm 13. And they said, "My goodness, you're the youngest participant we've ever had. And we won't mention your age," but then they turned to Mrs. Geller and said, "Norma, how old are you?" And she told them, and they said, "My goodness, you're the oldest person we've ever had." So you can see Norma and the family have been involved in multiple activities for many, many years. In recognition of her gifts to John Carroll and the greater community, Norma was the 2015 recipient of the university's Alumni Medal, which is the highest honor that John Carroll can give to its graduates. She's also the 2017 recipient of the Lifetime Achievement Award from Cleveland Jewish News Magazine. That award was given in honor of her many contributions to life here in Northeast Ohio and elsewhere. She was also the 2020 recipient of the Newton D. Baker Distinguished Service Award, which is given by Case Western Reserve University's Alumni Association. The award was for her dedication to civil service and social justice throughout Northeast Ohio. We would be remiss tonight if we did not honor the spiritual presence of Albert, Norma's husband, late husband, and best friend, and devoted husband for 69 years, and the father of Dan. I think this is the fourth lecture series without without Albert being here. But I would like to mention, I actually talked about Albert in my class today. I invited my students to this lecture, and I see many of you here, thank you for showing. But I also talked about Albert, because I talked about you, but then I said, and then she was married to this guy, Albert. Albert lived by two mottos. You only live once, so make a difference. And I hope I pronounce this correctly, Tikkun Olam, which can be translated from the Hebrew Bible as repair the world. That's the motto that Albert Geller brought to the world. That's the model that Norma Geller shared with Albert. Albert and Norma have generously given up their time and resources to education, to spiritual development, to social justice activities. They have lived a purposeful life. They have lived a life of service to others. They have lived a life dedicated to the Jesuit theme of cura personalis to the care of others. Finally, and maybe this is just an old guy, an old college professor talking, but as an indication of the mark that Norma and Albert have left on their world, all of their children have done extremely well. Two of the children, one son-in-law and one grandchild, are now doctors. That's a remarkable achievement, and it's an example of the outstanding legacy that Mr. and Mrs. Geller have left behind. Norma, you and Albert have clearly made this world a better place through your presence. You have our heartfelt thanks and our deep gratitude. And now, Dr. Chapman, it's all yours.
Thank you all so much for making it out this evening. So I have the pleasure of introducing our speaker. We've had a long sort of informal connection to Dr. Elaine Borawski. So let me tell you a little bit about her this evening. So Dr. Elaine Borawski is the Angela Bowen Williamson Professor of Community Nutrition and the Vice Chair of Applied Research in the Department of Nutrition at Case Western Reserve University School of Medicine. So she is in the medical school, but she is a trained sociologist. She is a medical sociologist interested in the social and environmental influences of health and health behavior, and the development and testing of new intervention strategies that draw from the strengths of the environments and the people who live within them. Her research has targeted a wide range of public health issues, including childhood obesity, health food access, HIV and pregnancy prevention, tobacco prevention and control. She's the founding director of the Case Western Reserve University Prevention Research Center for Healthy Neighborhoods, a nationally recognized community engaged research center committed to addressing health disparities in Greater Cleveland, focused on underserved and under-resourced urban neighborhoods. So let me tell you a little bit about her talk, but before I do that, I just want to say that we're so glad to have her here. For those of you that don't know, she's an endowed professor. They just don't hand that out. It's an amazing accomplishment. And let me give you a little tidbit. She's here to share with us her research of one of her multi-million-dollar grants. One of those grants is the work that she's doing. So she's had a very prolific sort of career. So she's well-funded, well-published, and well-respected over at Case University, Case Western. So, her talk tonight, entitled "The Role of Medically Tailored Groceries in Mitigating Food Insecurities and Improving Pregnancy Outcomes Through Clinic Community Partnerships," focuses on community-based interventions that address health food access among low-income and minority pregnant Clevelanders who are at a much greater risk of having a premature baby, contributing to the significant racial disparities in infant mortality in Cleveland and Cuyahoga County. She will provide a historical background on the root causes of poor healthy food access in Cleveland, the impact this has on maternal and infant health, and then share details of her 2 new intervention studies that address the impact of providing medically tailored groceries during pregnancy through sustainable community clinical partnerships. So please welcome with me Dr. Elaine Borawski.
Hi, everybody. Okay. Do I need both of these since I have it on my, do I need this too? Nobody's saying anything? Okay. Can you hear me if I'm talking just with this? Perfect. Now I need the mic. Okay. Thanks, Gloria. All right. And now I can't see you, though. I'll have to peek my head around. Okay. And then I have to do the slides, too, so we'll see. I'll stand here. I'll just peek around to see you. So good afternoon, everybody. It is really a pleasure and an honor to be here today. I really want to thank the sociology department, particularly Dr. Barnes and Dr. Chatwin, for setting me up and inviting me to this, but also to Mrs. Geller and your family. This is the spot for not just sponsoring this wonderful lecture series, but I've looked at a little of those that have gone before me, which is a bit intimidating because it really has focused on some of the most important social issues, I think, of society. So thank you to all of you for supporting this. Today, I'm going to give a little bit more. I think Sean basically gave a little. I'm going to drop down in my talk, because I think he already gave a little bit of what I'm talking about. But let me give you a little bit more background on myself. So even though my work is largely focused on behavioral interventions, health behavior interventions that are focused at the individual level, it's always been that contextual or those structural determinants and influences that have interested me the most. Not only those that are related to that behavior itself, but also as an interventionist, what is it about the context that allows somebody to actually uptake an intervention? And what are the things about the implementation of that intervention that makes it work? And I really do credit my foundational training in sociology for providing me both the conceptual and the analytic skills that I've really needed throughout my career in doing this work. So for the students in the audience, the sociological theories that you're learning about continue to stand the test of time. From structural functionalism to conflict theory to symbolic interactionism. These and others provide useful, and I may say practical, frameworks for looking at today's societal problems, and also the solutions for them. So I wouldn't say that I follow a particular theory, but I utilize theory to tell me about the things that we need to consider. It helps you develop the intervention. If you're thinking about the way in which power plays a role, or how interactions and relationships play a role, when you're developing interventions to address a problem, you have to think about all of those things. But not only that, but probably more importantly, which is the analytic side, you have to remember, you have to think about what things you're going to measure. Because a lot of this, much of what we do, it's one thing to do an intervention, but now you want to find out, does it work? How does it work? For whom does it work? Under what conditions does it work? And that is really what the work that I do. So this presentation, I think, as Dr. Chaplin mentioned, is we're going to talk about food insecurity here in Cleveland for the most part. I just realized how short I am, you guys. I need a little, yes, sir. No, it's okay. I'm just realizing you guys can't see me at all over there. So I think that we're going to talk a lot about, like he mentioned, just how we got to this place where food insecurity has had such an impact on disease and on really poor negative health outcomes of our residents. And so we're going to talk about how redlining, and I know a lot of you have heard about redlining, you know about it. We'll talk about it and also food policy decisions that have really shaped the city's food landscape. We're going to look at the challenges that pregnant women and pregnant individuals face when they're trying to access healthy food if you live in what we call a food desert. And I think a lot of folks don't really have a sense of what that means, but there are folks that live miles from a healthy place to purchase healthy foods, and they don't have access to transportation. And so you're going to see a little bit of that here in some of the data here in Cleveland. So what started this line of work for myself and for my colleagues? Sean mentioned that, so I'm very involved in a center at the university called the Prevention Research Center for Healthy Neighborhoods. And we created another center in 2001, and then we received funding to establish the Prevention Research Center for Healthy Neighborhoods through the CDC. And it is really intended to look at these large public health issues and not just as academics think, oh, what could be the solution to this? But instead engaging with community partners, engaging with community residents, engaging with those who are addressing these issues themselves, and engaging and co-creating things with them. And that is really what the Prevention Center does. So what really started some of our work in this area was a statistic that, I don't know how anybody can see the statistic and not see it after that, which is that Cuyahoga County has had one of the worst infant mortality rates in the country, and at a rate that is even worse than many developing countries. And it's been this way for over 30 years. So to say that this is obviously an ongoing problem, one in which finally I think there's been quite a bit of activity. Any of you that are interested in this area, there is something called First Year Cleveland. It's a very large consortium that was brought together basically to address infant mortality across Cuyahoga County. And so this really, this is really what struck us, but it's one thing to have a rate that's this high, but more importantly, and most striking, is that black babies, babies born to black mothers are 3 times more likely to die before their first year than a baby born to a white woman in Cuyahoga County. And even more striking, I want you to, and I know a lot of the students are probably not familiar with the county versus the city and that, but if a black woman, educated and employed, is more likely to have her baby die in the first year of life than a white, lower educated, and unemployed woman in the city of Cleveland. Why, right? And I'm just going to leave it there for a second because it is the thing that made a lot of us sit into this, lean into it, and say, and I'm going to, maybe it's not always the politically correct thing for people to say these days, but this is the example of structural racism. And you can't wrap it up any other way, right? And so I'm going to show you a little bit more about it, and it's more to give some more background of how this happens, and then I'll dive into these solutions. But I think it's really important, instructive to hear more about how we got here. And so one of the things we first started doing was like working our way back on the causal chain, right? So you have the infant mortality. We know that the leading cause of mortality, infant mortality, is premature birth. All right, so work backwards. These are babies born early and small. And so that we knew that was some place to start. But more importantly is that we know that food insecure individuals are 2 to 3 times more likely to deliver a premature baby than those that are food secure, okay? So that's one causal pathway. The other causal pathway is that food insecurity is also linked to a lot of negative mental health outcomes. So depression and stress and anxiety, which independently have impacts on healthy outcomes, on birth outcomes. So the combination of these two things obviously can have just serious outcomes, and ones in which, like we say about a lot of preventive things, should be solvable, right? We shouldn't have individuals that are suffering this level of food insecurity. So let me get my notes when I'm going off too fast here. So how do we define it? And I think it's important to understand that when you think of food insecurity, you typically think, oh, they don't have enough food. And that is true to some degree, right? It's a part of the definition. And so the USDA defines food insecurity as a lack of consistent access. Access is the key, right? To enough nutritionally adequate and safe food for every person in the household to live an active, healthy life. So that is the definition. So what you see in there is, okay, it is the lack of food, but there's different reasons for it. Now, obviously, the primary reason is the lack of income. If you don't have money to buy healthy food, you're obviously not going to, that is considered being insecure. But there are very large physical barriers to access healthy food today. And we call this living in a food desert, but lack of transportation is also significant, even if you have the funds you need. So let's see, let me make sure I'm off my notes here. So really, regardless of where you live, whether you're in the urban core or if you're in the rural areas and the farmlands, that this is still the definition of food insecurity. And so it's a mixture of income and access. So keep thinking about access, because most of us, if we want groceries, what do? We get in our car, maybe you get on a bus, maybe you take an Uber, but you go to the local grocery, you go to the Heinen's down the street, or you go, right? But for many, many people, particularly in this city, that is not an option. So I want to real quick, so if you don't know this as well, so we can look at things like access of grocery stores and that as a measure of food insecurity at the population level. But you can also ask individuals, and that is why the USDA created this questionnaire. It's used worldwide now as a way in which to measure food insecurity. And basically it asks individuals to tell them in the last 12 months, for your household, has the food that you bought, did it just not last? Or did you didn't have enough money to buy more? Or I couldn't afford to eat balanced meals. Did you cut the size of your meals or skip meals because there wasn't enough food? This is a very common thing for women, particularly with children, that in poverty will often not eat healthy and or skip meals in order to have their children eat. Do you ever eat less that you felt like you should, but there just wasn't enough money for food? And were you ever hungry but didn't eat because there wasn't enough money? So this is still about money and accessing, but you'll see it goes little bit further. So what this questionnaire basically yields a score of 1 to 6. And we categorize them typically in these 4 areas of insecurity. And we generally consider the bottom 2, so the low food and the very low food security, to be the individuals that are food insecure. So in a recent study, so as another thing that the Prevention Research Center does is we do a population level adult survey, and so it's called the Cleveland Health Survey. You may have even gotten a phone call to be involved in it. But it just recently reported that 30% of Cleveland residents experienced food insecurity in the past year, so as low food or very low, 30%. The Greater Food Bank, who serves 7 counties, so counties that are not all urban space, but 1 in 8 of their households are considered food insecure. And it matches up with poverty, right? I mean, our poverty level in Cleveland is 30%, almost 31%. And if you're a child in one of those households, 1 in 2 of those children live in poverty in Cleveland. So it just gives you that, I just want to, it's really to get a context, because I think sometimes we don't really have a chance to know. We don't go into the city. I'm going to show you now a project that we do, something called Sifter. And this is a program which I don't know if anybody from John Carroll's ever joined us, but every summer we hire students from all over the country. They come and they go out, a group of them goes out to and audits over 1,600 food outlets across the city of Cleveland every summer. So we have real-time data on what's going on inside of each of these food outlets across the city. Sorry. Let me get my... Yeah, sorry, I'm just sort of... Okay. So one of the things that we wanted to figure out was, okay, well, what is the access? What does the access actually look like? And what we find here is that in this past year, we documented only 12 supermarkets across the entire city. And remember that Cleveland goes 26 miles from up here all the way across to near Fairview Park. So 26 miles, and there are 11 or 12 supermarkets. And for some of you, you might look at these and think, my goodness, Dave's. I wouldn't go to Dave's. I wouldn't go to Walmart. These are the best of the supermarkets we have in the city, all right? Now, others would say, well, what about Aldi's? What about Save-A-Lots? You're right. We can add the second tiers, and you start to see some of the others. But these are the entirety of the supermarkets. Except for downtown, you don't see a Heinen's, right? You're not seeing a Whole Foods. You're not seeing even like the large warehouses that folks could go to. And I think one of the most important things you'll see in a little bit is that there's a definite difference between the east side and the west side of Cleveland, right? So the east side has far fewer any kind of food outlets than the west side. And so you might want to say then, so where do people get their food then? And so here is the identity of where all of the corner stores and convenience stores are. And these stores sell mostly snack foods, sugary beverages, alcohol, tobacco, but perhaps milk and bread, and some of the basic healthy food staples. And there are plenty of these options across Cleveland, as you can see. So you can understand, we can understand this. We basically go in there, and if you are interested, I'm going to provide at the end, if they give you the slides, there's a QR code that you can go to the map, which we call Fresh Finder, and you can look at any store in Cleveland and see what it offers. And we're using it mostly for dietitians and things that are, think about this, you go to your doctor, you're diabetic, the doctor tells you to go see the dietitian. The dietitian gives you this nice long list of all the things you're supposed to eat, and the patient's like, there's none of these places near me to be able to buy this. And so we're working with dietitians in our own department to help them understand that you have to understand the context of where these folks live first, and then try to build their meal plan. Don't go with the meal plan first of what they need and then figure out how they're going to get it, because you're not going to be very successful at that. All right, so just in order to show you, we developed a thing called the Healthy Food Index. And it basically was, okay, let's put a score to every one of these stores. and tell us how healthy the food is. And so they got a score if they offered fresh meat, if they offered whole bread, et cetera, et cetera. And the score could go from 0 to 36. And so this just gives you, now remember that map that had the 400 and some stores. That's the one at the bottom. So in general, those supermarkets do pretty well. So 35.7, 35, 34.9, they're pretty much at the top. They do offer the highest level, right? But once you get into these small groceries or the 400 and some corner stores, they're scoring a 5 out of 36. So chances are there's not much there that a person could make a healthy meal from. And unfortunately, what we know from other parts of our work is that individuals, particularly those that are on food stamps, they only go to a full-service grocery store once a month, right? So where do you think they're going if they're not going there, especially if they don't have cars, these small convenience stores? And so I'm just trying to paint the picture now. When you're thinking we have these pregnant individuals in front of us, what are we really, we need to understand that context in which they're faced with. Okay. So I'm going to try to go quickly through this part because I think you all have had some of the exposure to redlining and to those areas. So let's talk about in general though, like how did Cleveland get like this? How did other urban spaces get like this? Like this. And I would say there's two different theories on why we've lost all this, right? The first theory is a social economical theory, right? It's all about supply and demand. You're in a neighborhood now, and there's not a lot of folks with a lot of money. You have grocery stores that have a very, very small profit margin, somewhere between 2 and 3%, right? And so the only way a grocery store can really make its money is it has to have high volume. It has to have high volume, and it has to have a mixture of those kinds of high-end things that make them money. So what are those? When you go to Heinen's, it's the wine area, it's the beer area, right? Or it's the organic. It's all the things you pay a lot more for, right? And the volume allows them to make up for the basic staples. If they only sold basic staples and fresh produce, they would not make any money. And so the same thing happens in those 400 and some little stores. What can they sell? You're in a neighborhood where people have very little money, right? And nobody's helping that little corner store basically be able to offer anything more. So what are those items that they're going to sell? What's in it? What are they selling that has a high profit to? Yeah. Alcohol, tobacco, and now all the CBD and all those products are there, right? What else? Snacks. And what kind of snacks? Yeah, high processed. Ultra processed snacks are going to be, you're going to hear more and more about this, right? Because they are the cheapest to make, and you can sell them. They make the highest profit on them. And so, but they can still be made cheap enough that a small grocery like that, it's a mom or anybody going in is going to look at something. If I can buy this thing that I know my kid's going to eat, versus I'm going to buy a thing of blueberries that may or may not be even, next day may not even be good. I mean, the options and the selections are obviously not very good. So that's one side of it, and it's a very convincing argument. The other side is that it's about racial segregation, and that's why we see what we see in Cleveland. And I say this is a paper that I did with a doctoral student in geography at Kent State using our data to look at the impact of racial discrimination versus the socioeconomic, these two theories. He used some things far beyond my understanding of GIS and tested models to see which of these things made a difference. And in fact, he found that yes, absolutely, if you compare the city to the suburbs, economics explains a lot of it. But once you're inside the city, then racial discrimination explains most of that. And you can see it even because Cleveland is, if not one of, it might be the most segregated city in the country. And so it was actually, sadly, it was actually a great place to do this study because even though we have this racial segregation, inside of that racial segregation, there's there's variability in the income. And so then you can really look at the impact between these and the interaction between these things. So I'm not going to do this part, but let's just talk about redlining for a moment, okay? So everybody, I feel like you had a wonderful thing here last year. I think everybody saw. Okay, so without going through it, it's clearly has really just changed the entire landscape of our cities. Cleveland particularly, and a lot, I mean, it's true, most of the industrial cities have had a hard time coming back. But Cleveland in particular, and I personally think it's because we are older. We are an old city, right? And our boundaries of our city have been defined for, centuries, right? So when other cities wanted to get bigger and people were moving out into the suburbs because that's what all the advantage was, right? They moved to the suburbs, but there was no way to make it any bigger. So those suburbs contained Cleveland. Cleveland could never grow, right? Cleveland has stayed the same geographic size since its beginning. And so because that, and then there's the out-migration into the suburbs, then you're left with just somewhat of a shell of a city. And so, to say that this happened because, all the, people will say this, people all moved out. They moved out to be in a better place. They went to the suburbs. But we also know that when people came home from the war, only certain people were able to do that, right? So the government provided these loans, these government-backed loans, so that you could buy a very low interest, get a loan, buy a house in the suburb that were being built as fast as they could do it, but 98% of those loans went to white people. So, so then where were the African American, and not just, at that time, there was a number of folks that were redlined out, right? So if you had your color of your skin, your religion, there's all kinds of reasons why you didn't get these loans. And so now you're in the city, and what's your housing option? Rent. And what this video I love does is it says, over those period of time, wealth was built, but only for certain people. Because the great line in this, which I will tell you if you haven't seen it, there's three gentlemen in this that are all three really esteemed sociologists, which I love hearing, and their comments are so right on target with it. And one of they say is that you can't build wealth renting, right? And I think about this often because my own dad was a recipient of this when he came home. So he bought their little, I don't know, $5,000 house, however it was, and it sold for thousands of dollars, hundreds of thousands of dollars later. And that built wealth in my family, right? But what would have happened, and Rich will tell you about it, my dad had a good friend, and who was African American, and I think about that now, that had they come back, and both of them had been given that opportunity, could he have been our neighbor? Could all of our neighborhoods in the suburbs have been a totally different setup if the government had not done what it had done through its policies? So I mean, this is one of those things where I'm really not trying to be, not trying to preach. I mean, it's just one of those things where I think a lot of you may know what I mean when I say this. Once you see it, you cannot not see it. And it's these kinds of things, when you see these kind of policies, how in the world will it ever be caught up, right? It just seems like it will be too difficult. Okay, sorry, I could go on this for a long time. So basically, after all of this happened, right, urban renewal was obviously the cities were being abandoned. Again, the government says, here, we're going to put all this money and we're going to do urban renewal. But what do the cities do? The cities take all that money and they build more suburbs. They build highways, they buy shopping, we build shopping malls. We build everything to get people out of the city, right? And at that, what's really important then is that 2/3 of the people that were displaced in this process were African American and Latino. And then they ended up getting relocated to even more overcrowded areas. And as I say here, in Atlanta, 1 out of 9 were displaced. So I'm going to give you a real quick visual example. So this is a neighborhood in Cleveland called Kinsman. It's actually not too far from here. And this is a blurry but a good visual of a block part of Kinsman. So real quick, what do you see? What are the things you notice in it?
The houses are very close together, and it's right by the highway.
Lots of houses, right? Looks like a nice little neighborhood. Ooh, really? Oh my, okay. I gotta really move fast. Okay. But what you really see too is that, anybody see the railroad track? right? So we know that African Americans, when the migration happened, a lot of people came to work on the railroads. So this was a perfect place to live, right? You could work on the railroads, you have this wonderful neighborhood. And so this is 1970. Now what is the first thing you see? Railroads are gone, vacant land, and a power plant built. Because what do we know also about environmental justice? When you're going to build something, where do you build it? So there you see, this is 1970. Okay, now this is 36 years later, 2006. Wow. And this is even before the 2008 housing crisis. So houses were being basically torn down because they obviously weren't standing up any longer, right? So this is a neighborhood that has just really been stripped. And now go even 20 years, it hasn't changed much. So I say here, do the residents that live here today have the same access they did 50 years ago? No, right? And this was a red line neighborhood. Okay, I'm going to try to speed through this. So how do we get, let me go past all this. Okay, so if you live in the city of Cleveland and you're low income, right, you're very likely to not own your own home, to not own or have regular access to a car. You usually live 1 to 4 blocks from an RTA stop or a bus stop, more than 2 miles from a full-service restaurant. You have 2 to 5 corner stores or fast food outlets within 2 miles of your house. So not only do you not have a place to eat, get good food, but you've got lots of opportunity to buy bad food. And chances are your neighborhood might be a bit unsafe. So how likely are you to shop and be healthy and eat healthy if you're pregnant? So now we'll get into the heart of this. But I think, I hope I haven't depressed you terribly, but you want to do it to some degree so that you really can understand the struggles that I think, even us trying to find solutions, what's our opportunities to really do so? Okay, so I think I'm going to just go. Food insecurity, bad news, right? It has an impact on all kinds of things, from nutrients to pregnancy to health outcomes. But one of the things that's really important to think about, because we must, because this is how things get done here in our country, is that it's all about healthcare costs, right? So one of the things that we have learned in this process of developing these interventions is what we need to do is figure out how to push the needle on the healthcare costs. Because if we can do that, then perhaps these kinds of programs could be covered. And so there's a thing called food as medicine. If you've heard about it, and I will tell you, it's a little controversial, because some folks don't think food and medicine should go together, that food is a natural, it's a right that all should have, and we shouldn't be tying it to the healthcare system. But for right now, it is an area that is getting a lot of support. And so there are basically 3 different levels of food as medicine interventions. One is produce prescriptions. So that's where, if you go to your doctor, they give you a voucher, and you can go to the farmer's market or somewhere to Dave's, and you get $10 worth of vegetables. The thing that I work on mostly is this medically tailored groceries, which I partner explicitly with the Greater Cleveland Food Bank. And they basically, with their dietitians, develop medically tailored boxes of groceries that are delivered or are picked up by individuals that they service. And the last one is a brand new area around medically tailored meals, which is actually growing, especially in the area of diabetes, has really shown some amazing results. So I'm going to start now. These are the 2 studies I'm going to talk about. So the first one's called Nourishing Beginnings. And I will say this has been a labor of love. This is a pilot project. And it kind of emerged over a 4-year period with the partners of the Greater Cleveland Food Bank, as well as a number of other agencies. And I'll tell you about them in a second. But it's basically a program that tries to seamlessly connect a community health worker with a food box delivery system, right? So if you are pregnant and you've been identified as being food insecure, then there is a CHW is assigned to you, and then we link them up with food boxes being delivered to their house. And what we hope is that we'll be able to see differences in maternal and baby health outcomes to reduce food insecurity, reduce stress and depression, increase home cooking, and I think most particularly too, I think is to eventually see if we can't actually change healthcare spending. So What makes this a unique project is this is an on-the-ground program with all of the community health workers that come from these different agencies. Community health workers, is a good example, don't have a good method of being paid. So now, though, there are these things called vouchers that work it so that Medicaid pays them through their agencies, right, through a group called Better Health Partnership. And it's a really cool hub that we work with them. So basically, somebody gets referred, they do that, we connect them to the food bank, we do all the research behind it, and that's what I'm going to show you now. So our first study is 160 participants that have been referred to this community health worker hub. They're 18, they have to be less than 22 weeks pregnant, and then they're linked to this CHW. So in order to determine if these medically tailored groceries has an impact, we decided that we needed to randomize them to a control group. Does everybody know why you need a control group? Okay, well, one of the real problems, not a problem, it's something we deal with in community organization research, is nobody wants a control group, right? You cannot offer something to somebody and nothing to somebody else. So we were also very interested in knowing, sorry, I just realized that's there. Oh, that's this. We were very interested in knowing that, is it the food or is money? Like, what are the two things? Both of those things could, in fact, have a positive outcome, right? And so we randomly assign them to either getting these medically tailored groceries, or they get $30 every 2 weeks in a Cash App account. And there's also, I'm going to show you navigation and things like that. We collect data on them. We're going to control them, compare them to each other, as well as to a matched control sample. So this just shows you basically how the group is recruited. They go off to these two different groups. And so across the board, everybody gets $100 cooking. Because the first thing we discovered is that people they don't have pots and pans. They don't have even things to cook, right? And so every person at the beginning of this, they're able to identify up to $100 of cooking tools. They're delivered to their house. They also receive, basically, every delivery, they receive a pregnancy-specific tip sheet that relates to nutrition along with whatever week they are in their pregnancy. And then the food box basically gets the medically tailored groceries. They also, which is a cool thing, but it's not turning out to be as good as we thought, is that we wanted it to be like a HelloFresh, right? That you put you give a recipe and you make sure every item is in the box. Well, the food bank doesn't work quite that way. Their food comes in as it comes in. So it's been a bit of a challenge to make sure that they have these things, but the people they do like them if they use them. And then they get a little pantry box every 3 months that has oils and spices in that. So here's an example of what they see. They do get enough food for their entire household. It is based, they do a food preference sheet when we start with them, so we know what they like and we know what they don't like. And it's delivered to their house every 2 weeks. The cash group then gets the $30. And then I told you about the map, the Fresh Finder. The CHW sits with them and basically helps them figure out where they can go for healthier food, because they can actually look inside of each store to figure out what they have. And they also receive a cookbook, which, surprising to all of us, has become their favorite. They love this cookbook. So if you want a good cookbook, it's really a basic one, but they really like it. And so this is the Fresh Finder where we can put their address in. It gives a mile or 2 miles from their home, and you can then look and see what each one. Okay, talking about produce perks, we're going to go past all this. This is just, if you guys, as a sociologist, you guys should appreciate, we all love models. If you haven't come across conceptual models in your work, but it really does help to understand. So, right, we're looking at these 3 groups. We're obviously interested in the maternal and infant outcomes in the end, but we're also very interested in these mediators, right? So whether they'll improve their prenatal care, whether their food insecurity will go up, diet, et cetera. Okay, where am I time-wise, you guys? Can I ask? And what time am I supposed to go to?
We're trying to wrap up by 7:30. We do want a little bit of time.
I know. Okay, sorry. I knew this would go. Sorry. I'm going to go past this. So currently we're done recruiting, but we've just now started. We only have 113, 114 babies that have been born. So we still have another, 50 or so. You can look here. It's been a very successful delivery system. I think this is very special to me that we know now that we did a good job of recruiting who we wanted, right? And so we know that is predominantly minority, is lower educated. Most of them, but surprisingly not all of them, are on food stamps or WIC. and the age distribution is correct. Here's where you start to see some of the most striking pieces about so this is all their pregnancy history, right? So 90% of them had been pregnant, they've been pregnant before, and most have had children, but you can start to look at the sample versus the national numbers. So we have a 17.4% had a prior low birth weight baby compared to 8% of nationally. And you can go across. The miscarriage rate is the most dramatic. So over almost half of the women have had miscarriages less than 20 weeks, which in average for the same age group, it's about 15. Now, we could talk about whether women all know that they've had miscarriage. I mean, there's a lot that goes into this, but it's still a pretty dramatic change. Similarly with pregnancy loss, and then just the breastfeeding is interesting to me that there's a lot of, we'll be following up on this. So just a real quick brief about diet. So now these are the folks coming in. What you'll see, so they take, part of our data collection is we call them, and they actually ask them, there's a bionutrition core case, they call the individual, they do these little food things, and they say, they walk you back of what you've eaten in the last 24 hours. Believe it or not, it's our best method for getting food quality and diet quality. And there's a score that comes out of it called the Healthy Eating Index. The average, you should be able to get to 100. Virtually no American gets to 100. But the average is about 50. For pregnant women, it's about 65. And in our population, it's 47.3. So they are starting out significantly lower than they should be. You see at the bottom, and all of these, they're off. In the very bottom, the added sugar. So the sugary beverages are a targeted space, we think. And this is just another way of showing the healthy eating. And then we have been looking very closely at actual pregnancy nutrients to see, because we kind of feel like, okay, maybe we can't change some, but maybe we can hit the mechanism. So what if we can improve some of the nutrient levels? Because they're starting so low. So a third of them only meet one of 15 recommendations when it comes to the pregnancy nutrients at the starting point. And as you can see, only 22% are at 5 or more. Now, the question will be whether or not supplements and that can resolve that, but that's sort of a different question. Okay, I'm here to tell you, I just ran this analysis today. So we are not really showing our results yet because we obviously still have a lot of folks to go through the trial, but it's a little sad, right? So people that started out low food security, basically 70% of them stayed the same. Now 31% got better, so that was an improvement in their score. But go the other way, if they started out high food security, higher, let's say, because it's not all, they're all pretty low, there was a 11% decrease, and most of them stayed the same. That's good. We'd want that group to stay. We just thought this group would be closer to this group. So already we can see that there might be an issue with the dosage, right? If we're not able to even change the food security level, what's the chances of us being able to really impact the birth outcomes? And so here is a glimpse. You're seeing that not too many people have seen yet. These are just so this is at birth of I think it's 113 at this point. The birth weight, the percent of the low birth weight, the gestational age, there are no differences in the two groups. And that's not as worrisome, is that they're still higher than most of the norms. So we have a lot of digging to do. I will say that the good news is that we have secured what we call a match sample. So the Medicaid, one of the managed care organizations, is giving us a database, right, that they have matched for us on year of birth, age, race, and the zip code. So we will have a group of women who delivered in the same year, right, from the same zip code, and we'll be able to at least know, and we know their baby outcomes. So hopefully we'll know more once all of our data is done. So we'll try to get back. If anybody's interested, there's a really lovely protocol published. Okay, I just want to real quick jump into this next one, which is now, I'm thankful to all of you because I literally spent the weekend trying to put in some more of the results because we're just so behind on trying to put stuff out, but we're already funded for this new study. And so from the results that I've done this weekend, I realize now we may have to so when we randomize, you can choose, you can randomize and make sure that the two people before you randomize are from the same. So we may have to randomize on some things that'll make our group seem a little bit more different or a little bit more similar. So this is a program that is funded by the National Institute of Nursing Research. It is a multi-million-dollar grant, which is a little embarrassing, I think, sometimes to talk about, but the money goes a long way. I know. We're really proud when you're a researcher saying it, but it's, when you're working in communities and you're saying, yeah, the university got $5 million, $6 million to do this project. But it does go a long way because it's the food, right? It's all the delivery. It's all the things that goes into this intervention. And so we are partnering with University Hospitals and Metro Health. And in this case, there'll be no cash group. But both of those hospital systems, and if any of you are interested in this food as medicine, both of them have really established food as medicine programs and clinics. And so right now, if you're a patient with a concern around food, you will get a referral in the EHR to one of these. But both of them are clinics where you have to go and pick up the food. And we know that transportation's a problem, right? So that's okay, because that becomes one of our groups. So that is our standard care. And then so same group is the food bank. So we'll have 360 in the new study, and basically they will go pick up their groceries, or they'll get what the Nourishing Beginnings program has been, which is just a delivery with like the tip sheets and stuff like that. And then our third arm, which is the one that we're most interested in seeing, if we can probably also find out more about what's happening with them, it will have like a social media and a lot more educational and training, the ability for them to talk to dietitians directly and add a little bit more support to that. And so the status of this, I'm not going to go through any of this, sorry. It's the same, another model, same concepts. The only thing different, I think, is we are looking at some new things. One is stigma. So those of you as sociologists, that, stigma for both poverty stigma is one thing, but now there's known that there's programmatic stigma, right? Where people they don't want to be a part of a program. And so we're going to look to see what that plays in this, because the food bank does know that it's an issue. We just don't know what issue it plays with these interventions. The other one is the decisional fatigue, which has been now pretty well established in individuals living in poverty. It's just that they're just tired, right? Especially if most of our pregnant individuals have other kids at home, right? And so just as a real quick comment around it is that, people ask us, well, aren't they on WIC? So WIC is a government program, right? In Cleveland, we have about overall, we only have about 22% of people who qualify get WIC. You know why? Because you have to physically go to Metro Health every quarter, every month, or I think it's every quarter. You have to sit with a dietitian, which is a great idea, but you have to be there to sign up. And so now go back to all the things I showed you. You've got 2 kids, you have no car, you're getting on a bus line that may or may not be out by your house. Are you going to go every time and do that? No. And so it's another one of those things where these are systems level barriers that can be fixed. There should be no reason for this. Why is there only one place for this to happen? So now the food bank can sign up people for WIC. Now, all of a sudden, the numbers are starting to go up because they meet with them already. So as the food bank says, my goodness, it wasn't that hard. So again, we won't go past this, but so we are basically in our second year of funding. I will say that the first year was, very tedious. If you haven't been a part of a research team, there's a lot of work that gets to before you even get to do anything. IRB alone is its own little thing. And we also did a really intentional time with developing a patient and a stakeholder advisory, which we do for all of our projects. So we have a group of folks that have either been community health workers, that have been participants in the first study, helping us basically design this, but mostly that third arm of trying to help us understand that. And I will tell you, we were on a 3.5-month hiatus from NIH, where we didn't think we were going to get our money, and we got it. So we're starting to recruit next week. So this is that QRL, if anybody wants it, if you want to look at this is the map, if you want to see the Cleveland thing. So that's it. That was a very fast and so I am happy to answer questions now. My email is easy. It's EXB, the number 11, at Case. So if you'd like to reach out, please feel. I'm happy to talk to you after.
Thank you so much. Why don't we actually just do 1 or 2 questions?
I know, sorry.
I know, you have so much good information, so it was super interesting, and I appreciate you sharing all of it.
like a cause for like food insecurity and like the differences in like birth and like the outcomes?
No, but there are people that look at water availability, but mostly like I think in recreational, like outside spaces, not necessarily. I mean, Cleveland water is considered pretty good. So I don't know that I've ever seen anything. I don't know, Jim, do you know like more about too? Like whether there's ever been any ties to I don't know. It's a good question though.
I mean, I hope it's okay because we have the same water in Cleveland Heights.
Yes, well,
But thank you.
yeah, good question. Yes?
I thank you for sharing.
Yeah,
your
thank you.
research and all of your really deep intellectual thoughts on this. I'm curious, like, you mentioned once you see these things, you can't unsee it. And I feel like I often struggle with that and have a passion for social justice. Like, how do you encourage we can remain hopeful when maybe it feels like we're seeing these issues that maybe our individuals in power, individuals making policy don't necessarily see it or choose to not. How can we remain hopeful and steadfast? And what has like motivated you throughout your research in doing so?
Thank you. I will say the last few years have knocked me off a little bit more than, I mean, and I made a joke before, like, when you do this intervention work, typically you have more interventions that fail than, so I know I've had other people, I've heard a guy talk one time who said his entire career was failed interventions. It's like, what keeps you going? Because you learn something each time. And we are learning along the way, and we are moving forward. And, I think those of us that are older will say too that you gotta breathe through some of these times. But I would also say, and I'm just gonna be political if I can, young people, you are the future of this. Figure out what you're gonna have to figure it out, right? I mean, I think the rest of us, I have no what to say about it. I'm flabbergasted, let me just say that, about where we are. And so it's very hard to know, right? But I would say circle yourselves with folks, not just that agree with you, but can look for solutions for things and get involved. That's the best thing. And don't lose hope. There's always, it's a cycle. Everything's a cycle, right? Yeah. Anybody else? Yeah.
You talked about how this is going to be your second year of doing research.
Yes.
As you continue on, will you also be looking for any markers of like generational food disparity?
Ugh.
How being raised in a family can affect the pregnancy cycle?
Yes.
Those type of long-term research.
Yes, I mean, the person who's developing the third arm is very interested in that. And that is a part of that like thinking through what is it. And for a lot of these pregnant folks too, their mothers and their aunts are also influencing how they eat. And there's a lot of generational myths there around pregnancy too. So there's more than just the food piece. It's, so I think that there are enough people, I absolutely agree with you, that I think that trying to not so much as break that cycle, and I mentioned symbolic interactionism, right? It's about the meaning of food to people, right? And so the one thing we say about generational eating, is it generational eating or is it generational access problems, right? So if you change the access, would that change, right? But I will also say to you that we all, I don't know what, you just think about what your family background is. Think about your most favorite comfort food. Is it healthy? No. And there's that too. Whereas we have an awful lot of, and that's the harder part, is that when you can't afford to buy much, you're going to buy what goes the furthest, right? What fills your kids' bellies, right? And so, it's hard to separate out what's generational and what is just people doing what they need to do, and the situation hasn't changed, right? If the context would change and it was still that way, and it is that way with comfort food. That's why I said there's been some stuff written that says, people will say, I'm 3 generations out of poverty and I'm still eating all the bad stuff that my family ate, right? So, yeah, I don't know if that answered your question or not, but I can connect you to somebody that actually is doing that, a case that's very interested in that. All right. Yeah. Oh, are we done?
No, I was gonna say, let's make sure to have just one more question and then we'll start
Yeah.
wrapping it up.
How do you think current SNAP changes are going to affect pregnancy outcomes and also health outcomes in general, and if there's any research on that?
The SNAP benefits? Yes. You said, oh, yeah. So, this is, yes. So how will the changes in SNAP benefits and food stamps, how will those policies are changing, how would it affect? It'll be detrimental. And the thing is that we know not only will it be detrimental, because we've seen it before, but we knew during COVID, which is, I shouldn't have said, but there's no time to say, but that first pilot project came out of this thing where, if you remember at COVID, they doubled SNAP for almost 3 years, okay? In Cuyahoga County, if you were to look at the infant mortality outcomes, there's a blip. It improved. Went right back down, okay? Now, can we say it's because, some people say it's because people were home, other people they had more money. There was also no evictions. There were lots of things, obviously. But the point being is that all of those things did, in fact, improve outcomes, right? And the detriment is, yes. I mean, I think this idea of making people work is, you know, I understand the concept of it, but they obviously are not looking at the folks that are actually, the majority of people that are on food stamps are on WIC. I mean, most SNAP, we did our big study of SNAP users, most of them work. They just make very little money. No, I mean, when I looked at the income level of this, I'm like, this cannot be right. Like a third of our people make less than $5,000. Now, mind you, they probably have housing. I get that. And maybe they're getting food stamps, but their income overall is going to be less than, I'm sorry, students, but it'd be less than what you live on with a stipend, let's say. Like it's to think if you have 3 or 4 kids and you're living on less than $15,000. Again, you can do it, and people do successfully do it. But they do it because they have to go and buy the cheapest stuff they can find. And that's what's changed. The ultra-processed food has gotten significantly worse, right? There's so much happening right now. I think that what we don't see is that, and I'll just give you a quick, I went to Aldi's the other day up in Euclid, and I bought a bunch of things, and I'm looking at the back of them, and I knew this was the case, but if you buy cheaper stuff, look at the bottom, look at the ingredients. The list is much longer than if you bought that same thing at Heinen's, like the same basic product. Why? Because chemicals are cheap, right? And so if I can buy make potato chips for this much cheaper, that I can sell it for, it cost me 10 cents to make it, and I can now charge you $1, which is well within what you can buy. It's a win-win, right? Yeah, and so the health outcomes come with it. Okay, I'll get off my soapbox now.
Thank you so much for sharing everything you shared tonight. Thank you all.
Thanks, friends. Thank you all. Thank you.